Today, I will be talking about aplastic anemia and update everyone about advances that are happening in transplant and also in non-transplant options. I have no significant financial conflicts of interest relevant to this presentation, but I do want to disclose that I receive research support and also consultant and speaker fee from many companies that some of their products are usually used in the care of patients who undergo transplantation. What I hope to achieve today is to give you an update about treatments that we are using for severe aplastic anemia, but more importantly, to discuss with you and really help you understand the complexity that goes into that decision making and thus empower you to be able to ask the right question in order to advocate for yourself and your child whenever you talk to your healthcare team. This is really kind of a symbolic kind of balance of how do you make that decision. And it is obviously patients who are having bone marrow failure, including severe aplastic anemia, there are risks associated with their disease. We know that this could be a very life-threatening disease from a bleeding to infection risk, but we also recognize that the therapies that we are going to offer can have acute side effects. And in the case of transplant, there could be also importantly late side effect, especially when we include total body radiation. And in a difference compared to other indication for transplant, like in malignant diseases, there is no benefit of a complication of transplant called the graft versus host disease, where that donor can work as an immune surveillant and cause also what's called the graft versus leukemia and prevent the relapse. In the case of aplastic anemia, that's really not important, not needed at all. So we always have to balance that long-term side effect and complication with the disease risk and consider the other non-transplant options. With the important goal at the end is to cure everyone if possible with no late effect and no quality of life impact. I am going to go back to what Dr. Seth Corey presented at the beginning of today's symposium. And I want to emphasize how important it is when a patient comes with a diagnosis of aplastic anemia to potentially rule out inherited bone marrow failure syndromes, especially when they are young. And in the new guidelines issued by the NCCN, they emphasize on potentially ruling these diseases that I listed here through either functional assay or genetic test. And for today's purposes, I am only going to emphasize and discuss therapies for idiopathic causes of bone marrow failure, specifically severe aplastic anemia. But why I worry about this rare inherited bone marrow failure syndromes? For three reasons. First, together collectively, they are not rare as we really thought in the past. There was a study through the CIBMTR and from a single also centers that they looked into DNA samples from patients that they underwent bone marrow transplant for aplastic anemia, and they found close to 6% of them have other inherited bone marrow failure. And that's really important because that can influence how we treat this patient, influence how we counsel them. They can have a malignancy predisposition too. And second category of reasons, the implication for therapy. The way I treat Fanconi anemia, for example, and discretos congenita will be different. The conventional transplant regimen that it is used for aplastic anemia, we will have excess toxicities. And also importantly, especially in family donors or match-related or haplodonors potentially, the donor selection from a family will be important to look into a donor who does not have the disease, because we know many times some of these patients may not, or carrier of this disease may not manifest until a little bit later in life, and we may miss them through just regular CBC. And third reason is implication for family planning for parents. I think for these three reasons, I tend to at least rule out Fanconi anemia, rule out discretos congenita through telomere length, and if depending on the other history, I would rule Wachman-Diamond and DBA or other diseases. So moving now to the therapy part, It is fascinating with the origin, if we think about the two categories or schools of therapy with a transplant versus non-transplant, that they originally actually started as a transplant research. So the origin of the immune suppressive therapy, or IST, started as a bone marrow transplant trial using ATG from Dr. Mathey group in Paris. And they noticed that this patient that they tried to transplant actually recovered the count, but it was not with the donor cells, it was with the patient's own cells. And the successful bone marrow transplant that was done by Seattle group and Dr. Don Thomas was using more chemotherapy using Cytoxan or cyclophosphamide, as was reported the first case in 1972 in Lancet. What I am going now to go through the transplant first and then discuss advances and then discuss the immunosuppressive therapy. So you're going to see that there are many terminology that all describe bone marrow transplant. The more academic word, we use hematopoietic cell transplant, but you could see in different literature or different description, either a bone marrow transplant or peripheral blood stem cell, or even cord blood. And that describe the donor cells and the donor stem cells specifically. I put an asterisk here because I really want to emphasize that usually in non-malignant disease, especially in aplastic anemia, our preferred by far as the source of donor cells is bone marrow because it has less complication, especially chronic GVHD. So I love gardening, so I like to put this analog that a transplant in really essence is trying to get rid of the bad cells inside your bone marrow, and that it is usually done through this process of conditioning therapy, where it usually will include chemotherapy and some type of serotherapy that could be either ATG or sometimes alemtuzumab, and I said plus minus radiation depending on really the type of donor. Then the patient stays in the hospital during this acute period, and that's really the most dangerous usually because the risk of complication like veno-occlusive disease or acute kidney injury or other complication arise during this period. The one that we fear the most, it's the non-engraftment or rejection, which tend to be a little bit higher in aplastic anemia compared to the other indication. And then as the cells come, we monitor closely for acute graft versus host disease, which is basically the donor attacking the host, which is the patient. But after the patient engraft, and hopefully no graft versus host disease, they can be discharged. But we still monitor for some chronic GVHD symptoms that could attack the skin or in the gut or liver. But you could see in this diagram that I put infection as really a risk during all of these different periods in terms of early as we prepare for transplant and then later during the acute period or in the long term. But our goal is to basically be able to help the patient and prevent any infection or any graft versus host disease through appropriate medication as called immunosuppressive therapy that will prevent that and later to wean them to allow for immune reconstitution. And when we look into the United States, we see that aplastic anemia is very, very small percentage of all indication for bone marrow transplant. That is only around 350 annually. But it is this registry that it's called Center of International Bone Marrow Transplant. It is very useful because every center does a few transplants, but collectively we can look into all the data. This is all the centers that they do allogenic transplant report this, and we will able to look into the data and help us to find out what are the outcomes and how could we improve them. So over the last 10 years from 2007 to 2017, when we look for children less than the age of 18, and there has been close to 1,000 of them done, we see their outcomes is close to 93%. Versus if they get transplant from a matched family, from a brother or a sister, but if they receive it from a matched unrelated donor, that survival goes down and it is only around 80%. This is different when we look for adults. And we will see that percentage drops in terms of overall survival to be only around 80 with the use of matched sibling, and it decreased to around 70 from a matched unrelated donor. But importantly, and this is just the same diagram comparing the adult and pediatrics, but what I want to show is this, that there has been progressive improvement in the transplant outcome. So even in the pediatrics, when we look into unrelated, if in the 80s to the 2003, that outcome was only around 55%. But thanks to the advancement in infectious disease treatment, in immune suppression, and therapy for graft versus host disease, you will see continuous improvement. And we are approaching now, in the last 5 years, close to a 90% survival for patients in pediatrics who receive transplant from unrelated. And the same improvement has happened also with adult patients. So back in the 80s to 2003, that outcome was close from unrelated to only 40%, but now it is around 78% for patients who received transplant between 2013 to 2016. And we see increased number of patients who are undergoing transplantation despite that the period is getting less. And that allowed us then also to look to see what it is, how could we improve this outcome? I talked about infection advancement, especially in antifungal and antiviral, but also importantly, this increasing number of patients allowed us to do a clinical trial through the Clinical Transplant Network, or CTN, and find out that the conditioning therapy, the type of chemotherapy that we give for the patient matters. So our preparation for the patient matters, and there has been few studies that show that we can actually decrease the dose of cyclophosphamide, and in another study that was able to even take away the use of radiation therapy that has really more side effect potentially. This is the same or similar concept of that age matters and that the outcome would be different based on these patients. But with really more thought and more focus on the type of chemotherapy we use and advances in what's called reduced intensity regimen, we have learned now to even use other conditioning regimen. And this is a publication from Europe by Dr. Judith Marsh from Newcastle in UK, where they showed that using conditioning regimen of a fludarabine, cyclophosphamide, and alemtuzumab was enabling them, even in older patients who are older than age of 50, to achieve very impressive results. So for patients who are lower than 50, the overall survival was 96, but really admirably is also the outcome for patients who are older than 50 with the overall survival of 86. But I want to bring your attention to even the right side diagram, which is here a term called GRFS, which it stands for graft versus host relapse-free survival. In practical terms, this study showed that you could achieve 94% survival without really any long-term complication that could impact on that patient. And that's for above age less than 50, and for older people, that outcome was 84. So this regimen was not only good to make sure patients don't have toxicity, but it was also very good in preventing patients from having graft versus host disease. And moving a little bit in advancement, not only in the conditioning therapy, but one of the major limitation, if you go back, sorry, I'm making your head spin. One of the challenges we had here was finding donor, because I told you we will look first for a family member, but then we look into the National Marrow Donor Registry, which is unfortunately made usually mostly from Caucasian, and African American or other minority will have a very low chance to have a appropriately matched donor. And that's really why this is so significant, is the development of haploidentical transplant. And even if you look into this amazing study that was published and reviewed by Dr. Young in the New England Journal of Medicine 2 years ago. He reported on many studies, but at that time, really mostly they were in young, if you look at the median age, except of the Johns Hopkins study here, and also King College, that they had adult patients. And the number was at that time really small, but still had impressive survival. If you look into the overall survival, was 100% at 21 months. And I'm very happy to report that Johns Hopkins reported their outcome now on 47 patients, and the median age for this patient were 25, ranging anywhere from 3 to 69 years of age. And if you look into the left, the outcomes for patients who were refractory aplastic anemia here, or they were relapsed after they respond, all of them engrafted and they are survival. There was an issue with the treatment naive. They only 86% of upfront severe aplastic anemia engrafted and they were alive. And on the right side, it continued to show the promise of how haplotransplant and the use of post-transplant cyclophosphamide seem to be very effective in preventing graft versus host disease, because the rate of acute GVHD was only 11%, and the rate of chronic GVHD was only 8%. And if we look, that was really very good compared to even with a matched sibling bone marrow transplantation. And this outcomes doesn't seem to be unique only here in the US, and they seem to be even replicated internationally. So there are studies that it is published ahead of print in the Journal of Transplantation, and the group led by Dr. Park from South Korea reported a similarly impressive number and survival in patients who underwent haplotransplantation for severe aplastic anemia with really very good follow-up, close to 5 years if you look here. And their improvement, their survival rate was 82.3% for all the patients. So this is making another choice available for patients who in the past may not have the ability to undergo bone marrow transplantation simply because of their ethnicity and the lack of donor. So moving now to the second part of the talk, which will emphasize on advances in immune suppressive therapy. The cornerstone of immune suppressive therapy has been the use of ATG. And there are two types of anti-thymus globulin that are, depending on the animal that's being produced, either horse or rabbit. And there are different pharmacokinetics for and immunokinetics depending on which animal is the source of this ATG. And the dose here that it is listed, it is for the horse ATG, where I will show in the next slide why it is our preferred method for the immunoglobulin against the T cell. And we usually in our center do add usually steroid for around 10 days, and we may give it for as long as 28 days if serum sickness happened. The other thing is cyclosporin. So ATG and cyclosporin, the cyclosporin is usually given for around 6 months, but we tend to see so many patients who remain dependent on it. But if the counts are stable, then for 3 months we can stop them. There are some small series of using cyclophosphamide, mainly from the Hopkins group and other centers, but the mainstream use is ATG. And this is the common side effect tend to be allergic or serum sickness, or due to the immune-mediated cytopenia, we tend to see prolonged lymphopenia and increase of infection. This is the study that by Dr. Scheinberg and Dr. Young group at the NIH that showed that horse ATG is superior to rabbit ATG in response rate at 3 months, at 6 months. You could see that a complete response was 68 compared to only 37 when it's using for rabbit. But importantly also for the patient who undergo then bone marrow transplantation, we do see later an improvement in overall survival for the whole group of patients who received horse ATG compared to the one who received rabbit ATG. For cyclosporin, the side effects tend to be temporary and including from T-cell inhibition to hypertension that commonly require antihypertensive meds, hirsutism, and gingival hypertrophy. But importantly, I worry about nephrotoxicity for this patient, which many patients, when they come to transplant, if they failed IST, tend to have decreased glomerular filtration rate and hypomagnesemia that it is temporary. I want to highlight an effort that it is done collectively for the pediatric centers who are treating aplastic anemia in many of the hospitals. They formed many years ago what's called North America Pediatric Aplastic Anemia Consortium, or NAPAC. And that consortium did a retrospective study to look into how the centers that are part of the NAPAC, what's their experience with aplastic anemia, because most of the literature has been focused on adult and mostly in clinical trial with specific criteria. So it's good to have real world data. And if we look into the patient, and the number here was in terms of how many of them achieve really complete response and normalization of the count, that was approximately 60%, and another 8% that was very good response. But if you look into the graph in the middle, you will see what's called the duration of response after IST, and you will notice that continuous drop as late as 5 years after the therapy. But importantly, that many of these patients, even if they lost their response, they were able to be receiving second therapy. Most commonly, usually in pediatrics, it tends to be transplant. And that's why their overall survival remained very good. It's around 80%. And that's really important when you look into comparison of different therapies for aplastic anemia. Don't just look into the overall survival, because it is great that we have good therapies now that they lead to improvement in the survival. But what about this patient who get therapy multiple times and then later get transplant? What kind of quality of life they will have? What kind of possibly long-term complication they may have? And that's why we need more clinical trial. And I'm so happy we'll have Dr. Arnold to go over some of these studies and results. And not only in the US, but also in the European, that they show that similar kind of data and survival for patients who receive immune suppressive therapy for aplastic anemia, depending on the age. So overall survival tend to be around 82%, which is similar to what I showed you a little bit, but that start to decrease with older. And if they receive bone marrow transplantation upfront from match unrelated, from match sibling, that outcome, at least in the EBMT, was 86, and they continue to decrease in age, similar to the CIBMTR data showed earlier. And the unrelated was really impressively similar to the match related, especially if it is a young child with the age of 1 to 10, but it continues to decrease depending on that. So if I want to summarize the IST therapy and we notice that there are short-term survival that are excellent in terms of response, but that many of these patients tend to require and depend on cyclosporin, or they will recur. And that time frame to response tend to be a little bit longer. Both from normalization of the count tend to be close to 3 to 6 months. And also occasionally, not a very high percentage, but still we see what's called persistent or possibly development of a new abnormal clone that could increase the risk of development malignancy. And because of that, there was a need in the field that how could we improve on the immunosuppressive therapy? And the group at the NIH, led by Dr. Young, and this great publication, seminal paper by Dr. Tonsley, showed that if we add to that cornerstone of ATG and cyclosporin, if we use a medication called eltramabag that was approved for therapy of ITP, which is an immune-mediated thrombocytopenia, and they use different cohort to see how could it be interacting. And to their really surprise, they found that So the patient in this cohort, number 3, sorry, it is a very busy slide, but I will try to walk you in this cohort number 3, if you focus on the response rate at 6 months, you will see that overall response was close to 94%, and the patient who achieved complete response was 58, and the patient who received partial response was 35. But this is a huge improvement if you think about this, comparing it to the 80%. But this is really was a study that mostly included adult patients, but there were few pediatrics. And this led to an important study that just reported in August of this year at the EBMT. The difference between the RACE trial that was led by the EBMT and the study from the NIH, that it was randomized study. So the previous study that I showed you, it was a single arm patient, but in this EBMT that included close to 200 patients, and they included age 15. I wish they included more younger patients, but that's okay. And close to 7% of their population was that young patient. And they were randomized to either standard horse ATG and cyclosporin or a standard IST plus eltramabag at the dose of 150 milligram. And that was started from day 14 until 6 months. And this was their baseline patient, and you could see that it was very similar, no big difference. And I'm happy to report that at their median follow-up of 18 months, they noticed significant improvement in the complete response rate of 21.9 with the eltramabag arm compared to only 9.9. But the bigger number that was important, and that's the one we use a lot to decide if the patient need to go to transplant or not, is the response rate at 6 months. And that rate was 76.3 compared to only 50% for the standard arm. This is really practice changing, especially for adult sickle cell, for adult severe aplastic anemia. And this study, in addition to the NIH, has led to the approval of using eltramabag by the FDA to treat aplastic anemia. I would have to say from just a personal experience here with the young that we really need to have more data to decide if we are going to be as exciting as the adult data. And there is an ongoing study through the NAPAC to use eltramabag in addition to cyclosporin and ATG and in pediatric patients in prospective pattern and see if that truly stands still true in pediatrics aplastic anemia. Importantly, also, there is a recent publication from the NIH that it's using eltramabag in moderate aplastic anemia or unilineage. And I am very excited actually about this because some of the patients here were actually Diamond-Blackfan anemia. There was one patient in this group. And you will see in the diagram here in the bottom, any kind of red or blue or purple, it shows you the improvement. The gray is patients who were ineligible for the study. And in summary, even though the numbers were small, 12 out of 17 of this patient responded to this therapy and became either transfusion independent or normalization of that unilineage. But the problem was with this, that majority of them lost their response when eltramabag stopped. And a good thing is still that when it was resumed, the patient were able to continue to respond to the therapy. So in summary, really to try to compare transplant versus ATG, cyclosporin plus or minus eltramabag, the data that exists right now, it is mostly based on retrospective studies. And those tend to be biased for different reasons, either center interest, center preference, patient preference. So there are many biases that it make it sometimes hard to compare apple to apple. But it is good that we are seeing continuous improvement in general for outcomes, either with the transplant or with immunosuppressive therapy. There are different shapes of how the disease-free survival curve. In the immunosuppressive therapy, we tend to see that better 6 months, better short-term survival, but higher rate of relapse, higher rate of clonal evolution, and that the curves continue to decline. But most of this patient with the improvement of supportive care can be salvaged usually with the second line that tend to be transplant. The difference between it and transplant carry higher risk upfront. We know in terms of toxicity to the organ and transplant-related mortality, also the risk of infection. But what we notice that the curves plateau after 2 years, and that's really because the patient, if they engraft and they don't have GVHD, they tend to really do very well. I think it is important to recognize that improvement in unrelated and haplotransplant has contributed to the improvement in transplant overall. And with that, I want to finish in terms of really important study that it is going on now, that it is prospectively looked into, and they published the feasibility outcome of this. This is a study called the Transit, where it is comparing a randomized patient who are usually diagnosed with a severe aplastic anemia children. The question was, can you actually take them to unrelated bone marrow transplant? In pediatrics, as I'm going to show you in the last few slides, we will use match-related as our standard of care usually, because the children you don't have comorbidity or others. But it has been usually for if patient doesn't have match family, we will defer the transplant and we will use immunosuppressive therapy. But this study tried to change that and trying to answer the question, one, can bone marrow transplant be offered in reasonable time, and find out what are the outcomes. And this publication showed that it was actually impressive how quickly the logistics of transplant could be arranged. Within 16 days from the screening, the patient were able to be randomized. And I think that's very important because we tend to have the workup that includes cytogenetics, includes sometimes genetic workup, telomere, and chromosome breakage to rule out Fanconi. So we're really rarely able to be starting any therapy, even IST, before, let's say, 10 days to 2 weeks probably from the diagnosis. And the median time to start BMT was 36 days. This was really impressive because remember, those are unrelated donors. So it needs coordination with the donor center through the NMDP, and the NMDP played a great role in terms of facilitating that. And in terms of the outcome, there were 11 patients randomized to the immunosuppressive therapy. So 6 patients responded very well, and 4 achieved CR, and 2 achieved a very good partial response. 3 patients failed IST and required transplant, and 1 was a poor response. In terms of patients who undergo or agree to bone marrow transplantation, 10 of them received transplant as first therapy. The median time, as I mentioned, was 34 to 60 days. And 1 patient had late rejection, 2 patients had acute GVHD, 2 patients has limited chronic GVHD. So this is a preliminary, it's just about feasibility, and there is now an ongoing study that I think it's in 34 centers to look into the outcome in more details. So in summary, what I want to finish is this algorithm that was proposed in the New England Journal of Medicine that I mentioned earlier by Dr. Young. And really, this is kind of the care path that it is similar to our center and many other centers. So for children who are younger than age of 18, if you have HLA matched sibling, you go to allogeneic bone marrow transplant. That has shown that the outcomes are above 90% consistently in the modern area of transplantation. And traditionally, we usually give immunosuppressive therapy with cyclosporin ATG, and the data is now supporting to use elatrimumab, at least in adults and young adults, and to some degree in pediatrics. And if they fail immunosuppressive therapy between 3 to 6 months, you could go to unrelated or haplotransplant with the best available donor. There, you will see that there is a dotted line here because there is really an ongoing now studies as I highlighted by the Transit, or there are other also centers, especially in Europe, who may go as a first line for an alternative donor from either match unrelated or haplo donor or umbilical cord blood transplantation. On the right side of your screen, you will see that diagram address what in adults therapy will be, immune suppressive therapy, if the patient doesn't have match sibling. But if you have match brother or sister, or what we call the match sibling, you proceed with bone marrow transplant. And if the patient does not respond to immunosuppressive therapy, there is a proposal to use a second here immunosuppressive therapy. But I would argue that really with the data, especially from the Newcastle group, the outcomes are very good, that it is really for this patient, it's worth considering with the match unrelated donor or haplotransplant, but that will depend on how the patient is doing, what kind of comorbidity they will have. And that's really why it's so important to have that clinical discussion with your primary care and primary hematologist to be making the decision that it is best for you and for your family. So my takeaway, it's really that we have now many good options for severe aplastic anemia. I think accurate diagnosis is really very important of acquired versus inherited bone marrow failure, especially for young patients and young adults. The outcome with either one, it's continuing to get better, and choosing between the immunosuppressive versus the transplant relies on the age, relies on availability of donor, the comorbidity of the patient, and that really patient preference at the end. This has to be taken all into an account and what it matters more for the patient. But I want to emphasize that transplant nowadays is very different from transplant 20 years ago. So I would encourage you to seek BMT consultation early so you could know at least what are the options. And finally, I would encourage you tremendously to consider enrollment in a clinical trial, because that's the only way for us to learn and to be able to advance therapy and make an impact for future generation and future patients. With that, I'm going to end, and I'm happy to take any question.
Thank you so much, Dr. Hanna. We have a few questions. Our first question is, can aplastic anemia develop into further diseases, such as cancer or something else?
Thank you so much. This is a very good question. And what I showed in the 2 slides earlier at that algorithm, it's so important to observe this patient that who have aplastic anemia, because they can have an abnormal clone and they are at risk for developing an MDS or AML, especially if they only received an IST and they didn't receive a curative bone marrow transplantation.
Thank you. Does the effectiveness of transplant, is it impacted if the patient used immunosuppressive therapy first and then went to transplant? Does that have an effect on the effectiveness of a transplant?
Very good question. I think there has been a lot of retrospective study trying to address that question. I think that slide from the CIBMTR, it shows that there are continuous improvement. So I would say in brief that the effectiveness may not be impacted, but some of the other complications can make the outcome not as good as if the transplant was done upfront. Specifically infection. If the patient received IST and he remained or she remained neutropenic and developed fungal infection, if you go to transplant with a fungal infection, your outcomes may not be as good as if you went without an active infection. But that's a difficult decision to make, because we know still, if you get an IST and with the modern transplant techniques and supportive care, there could be on average very good survival, close to 80%.
Thank you. Is if your first transplant you do not have a good response, is it suggested to have a second transplant, or could the patient have ATG? What is the preferred method of moving forward from a failed transplant?
Very important question. And as I highlighted that sometimes we see increased risk of what's called the graft failure, which means that the transplant did not work. And really depending on what's the outcome, occasionally we see an auto reconstitution, meaning that the patient can recover after the transplant with their own count. And I think at that time you could just watch and no need to do anything, even if they failed, because sometimes transplant can be part of immunosuppressive therapy. It's similar medication we use, ATG, cyclophosphamide. On the other side, if the transplant failed and the patient did not have any white blood cell, and I emphasize on the white blood cell because really most of the risk for death comes from infection, although there is still risk of a bleed-related mortality. In this case, in a primary graft failure with no recovery or bone marrow aplasia, I do recommend to move to a second transplant quickly, actually, so you could restore the neutrophil and prevent any fatal infection. ATG alone usually doesn't work. Most of the transplant upfront would have used ATG, and we tend to use other agent when we use a second transplantation.
Is it well established that horse ATG is more effective for transplant over rabbit ATG?
I am very impressed by our participant. That actually, it is an area of debate. If a patient did not receive a horse ATG upfront, or they basically got transplant from upfront, and the data doesn't say that horse ATG specifically is better than rabbit ATG. There are some differences, especially when it comes to risk of GVHD, but engraftment tend to be potentially similar. So the data that I presented, it relates to immune suppressive therapy, and that horse ATG is better than rabbit ATG in immune suppressive therapy.
Thank you. Our next question reads, if a patient is a 7-year responder from immunosuppressive therapy and is relapsing, but is now responding to cyclosporine, should they consider a transplant?
That's excellent question also. And I think really those were important to discuss this with your healthcare team. Depending on the patient and their comorbidities, I think after 7 years, it is very reasonable to just introduce immunosuppressive medication like cyclosporin or plus minus eltrombopag, but those really need to be discussed with the primary team who knows more details about the case itself.
Thank you. If an aplastic anemia patient has been doing well, but now has developed PNH, should a transplant be considered, or would using one of the FDA-approved therapies be more of an option, since transplant is not commonly used for PNH?
We see frequently concurrent PNH clone at small percentage when we have an idiopathic severe aplastic anemia. It's actually one of the things when I see that, I feel less concerned usually about inherited bone marrow failure. Having said that, usually with immunosuppressive therapy, even with the response, we occasionally see increased rise in that PNH clone. And depending on what it is the manifestation, if it is bone marrow failure manifestation, that becomes a challenge and they may need transplant. But if it is hemolysis or thrombocytopenia, then I think it is absolutely what I will do, usually use one of the FDA-approved medication to inhibit the complement and see the response to that therapy.
Thank you. If a patient with very severe aplastic anemia received horse ATG and rabbit ATG without any response, should they receive ATG to prepare for transplant?
Very good question. It's really going to depend on what kind of infection they have. They usually do need an immune what we call serotherapy, not to treat the aplastic anemia, but to decrease potentially the graft versus host disease. So we tend to use ATG still, but it will depend on some other factor. Occasionally, we will switch to another agent called alemtuzumab, but those will be based on the specific case.
Thank you. For a patient with moderate aplastic anemia, is it recommended that they use eltramopag proactively without ATG and cyclosporine?
So in moderate aplastic anemia, there is really no clear guidelines, and that's something we are looking into it with other pediatric centers. The general rule, it is really depending on what line of therapy to try to treat that. We don't always use ATG and cyclosporin unless the patient become transfusion dependent or they are neutropenic and they get infection. But the data from Dr. Dunbar is very encouraging to use eltramabag in these cases of moderate, but that's a small case series, and we would need a larger studies and clinical trial to see if that will be still true in a bigger volume of patients.
Great. Well, thank you, Dr. Hanna, for sharing your time and your expertise with all of us today. If you'd like to watch this session again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, you can send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. This conference session will end, and if you would like to rejoin the conference, please use the same Zoom link or phone number which was provided in your conference registration email. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to support you and your family as we have done for the past 36 years. This concludes our session.